As a major trauma centre, the emergency department at CUH receives patients from the whole of the East Anglia region, and many of them have severe injuries, including head injuries. Last year, over 106,000 patients came through the emergency department doors, and every year the numbers grow. In fact, the number has grown this year alone by some 6%. Many patients need further treatment and to be cared for on a ward. So when the hospital's wards are full to capacity, the patient has to stay in the emergency department.
The longer a patient stays in our emergency department, the higher the risk for that patient. Our aim in the emergency department is to make sure they get the timely treatment and they move on to the next part of their journey.
The longer it takes for patients to move to the next stage of treatment, the greater this problem becomes. Where will they go from here, and what can be done to relieve this unrelenting pressure? Who has the power to help?
Patient care and patient flow within this organisation is the responsibility of each and every one of us. We all need to work collectively in terms of improving patient flow and to free up much needed capacity.
A patient who arrives in the emergency department is booked in by the receptionist, cared for by the team in the department, and then be a member of the portering staff who takes them to somewhere like scanning or to the ward. Once they arrive on the ward, their care is taken over by the nursing and medical teams in those areas, and then there are all the other members of the wider team who play into the patient flow.
There are many reasons why patient flow is disrupted and why there are delays, and as the operations centre we can actually see where those delays are. We have lots of resources that we can use to try and mitigate those delays and enable patient flow to happen as smoothly as possible.
Those minutes of delay make life difficult for our patients, both emergency patients and also patients wanting planned care, but they're also very frustrating for members of staff, our nurses, our doctors, our allied health professionals, our managers across the organisation. Where appropriate, every patient or their carer or their family and support network should know where the patient is on their pathway through the hospital and should know what's going to happen to them on that day.
A large proportion of our inpatient beds are occupied by elderly people, not just in the elderly care wards, but in different specialties across the Trust. This group of patients is particularly vulnerable to deterioration in their general physical condition, even if the primary reason for them being in hospital is being successfully treated.
A statistic often quoted is that every 10 days a patient over the age of 80 spends in a hospital bed ages their muscles by the equivalent of 10 years. Keeping patients mobile avoids this deconditioning. Avoiding moving them around multiple wards reduces the chances of them becoming confused, which means when they're well, they can go back home without the need for complex discharge planning and additional support. The specialist advice for the frail elderly or SAFE team aim to help support patients in other areas. One of the most important things when looking after an older patient is to establish what we call their functional baseline, what they're able to do at home before they came to hospital and what support they had. Finding this out lets us know what we're aiming for so that we can keep people mobile and get them back to that level more quickly.
The Red and Green Day tool is a simple way for MDTs to identify and act upon blocks and delays in the whole patient pathway.
We highlight patients each day as to whether they're red or green. So if they're red, it means there's something that's stopping them from leaving the hospital that we need to do for them to go home. If they're green, it means that their treatment's all going to plan and they'll be able to go home as soon as possible.
It lets us identify, for example, that there are delays accessing angio for patients, and it then lets us work with the angio team to say, what could we do to give you more resources to be able to provide more timely care to our patients?
Well, if you're an inpatient waiting for an endoscopy and it was happening tomorrow, that would be a waste of your time, that would be a red tape. So to try to improve things, we might phone endoscopy and see, is there any chance this patient can have their endoscopy today?
And at the end of this, the patient wanting that care, needing that care, gets it in a timely way. We talk to our patients and our staff about the values of the organisation, and we agreed on values of together, safe, kind and excellent. And our current work with patients and staff on patient flow absolutely relates through to our trust values. So individuals taking accountability for improving patient flow themselves but working together in their teams is what ultimately delivers care that's safe, care that's kind and care that's excellent, and that is ultimately what we're all trying to do for our patients here at CUH.